Good morning, good afternoon, and good evening for those that are joining. My name is Anafi Mataka, and I'm delighted to be your host today. Today we have a very important and interesting topic, and we have titled today's session, Unlocking the Potential of a Tiered Laboratory Network through Laboratory Mapping. What we are trying to do today is to understand why and how mapping and network optimization can be so powerful, can be a powerful way of designing a diagnostic network in order to strengthen lab systems for public health impact. This will be a 1 hour long session that will be made up of a presentation followed by a question and answer segment. Throughout the session, we encourage you to put your questions and comments into the chat box, and we'll attend to these immediately after the presentation. I'd like to remind you that there is simultaneous language interpretation from English to French. Please choose the language of your choice. From my screen, you actually find the icon of a globe at the bottom of your screen. If you are using a computer, you need to click that and choose either French or English. I'd like to introduce today's presenter, and I'm honored today to be presenting my boss, Dr. Pascal Ondoa, who is the Director of Science and New Initiatives at the African Society for Laboratory Medicine, and she has been in this position since 2017. Dr. Ondoa is a medical doctor and virologist with over 20 years of experience in the field of HIV and project implementation. She has expertise in virology and immunology, basic and applied research in diagnostic development, implementation, and laboratory system strengthening, especially in resource-limited settings. Dr. Ondoa has extensive experience in developing tools for laboratory systems assessment, policy analysis, and laboratory strategic plans. She is affiliated at the Institute of Global Health and Development at the University of Amsterdam as an assistant professor. Ladies and gentlemen, I would like to turn over to you, to Dr. Ondoa.
Okay, thank you very much. So, good afternoon, good morning, everybody, and thank you very much for coming with so many to this session. And I will stop my video just to concentrate on my presentation, if that's okay with you. So today we are going to talk about unlocking the power of the tiered laboratory network through laboratory mapping, and really mapping network optimization, test integration. These are words that are really coming back often in our conversation. And I will, show you some examples of what can be done with collecting and analyzing data on laboratory network. So I always like to go back to the basics when I do the presentation, and really start with the questions that are the fundamentals of why we are doing things. Why are we doing laboratory mapping? So, and it's to answer a very simple question. We want to know, where are the laboratories? Where are they located? What can they do in terms of diagnostic? And how much population is covered by the laboratory services? So this information can be used to improve the function of the laboratory network, and of course to strengthen the capacity of the laboratory technical working group to manage their own laboratory network. If you don't know what you have, it's very difficult to manage your services. So let me reintroduce to you some basic notions and what exactly do we mean when we talk about national tiered laboratory network. So this is a figure that I borrowed from an article from colleagues from the US CDC ILB that really have a lot of experience in providing tiered services. And I took the example of HIV because I think that's where we have most of the experience. And you see here the pyramid shape of the laboratory network, which mimic the pyramid shape of the health services. And you can see that from top to bottom, you have a decreased specialization of lab cadres. And then from bottom to top, we increase the complexity of the test and the diagnostic. And here for HIV, we can see that at community level, there are point of care testing, rapid tests, and then it goes progressively up to ELISA test, CD4 count, the viral load, and then very complex tests at reference level, which can be HIV genotyping. So please use that as an example, because we will talk about more than HIV today. So behind this tiered laboratory network, there are a lot of systems that have to work together in order to make this structure deliver the services that they need to deliver. And some of the things that the network have to do is to address communicable diseases, and not only for the human health, but also at the human-animal environment interface. Also, the tiered network has to address non-communicable diseases. And that has to be done when we have some requirement to integrate the services, so that when a patient enters the health system, it can really find everything that he or she needs within one tiered laboratory network and not go through separate networks. There is also a requirement of quality. The test needs to be reliable. There is a requirement for access. Everybody in the country, it doesn't matter if they are in a city or in a village, should have access to the laboratory services. And of course, there is a requirement of efficiency. We need to impact the clinical and the public health outcomes. This network also have other terms of reference. It has to function into routine situation and emergency situation and deliver for individual patient health, public health, and global health. Like we see with the pandemic, it is not only a country problem, but it's really a global problem. And of course, the trick is to do all this in a context of limited resources. So there are a lot of terms of reference for this tiered laboratory network. Now, if we would use a metaphor and compare the laboratory network to a computer, what would that mean? That would mean the laboratory systems, that when I say systems, it means the infrastructures, the supply chain, the equipment, the workforce, the quality and the data. This would be the hardware of your laboratory network. And then when you look at the tier structure of the network, we could compare it to a software. It is an environment that gives you the opportunity, the constraints, and the opportunity to neutralize your resources, make sure that everybody accesses the system. You synergize the functions, you have the clinical function and the public health functions going hand in hand. You create cost effectiveness because you collaborate within the network with your sample referral or with outsourcing of services to other tiers. And of course, you have to cover the population need. And one laboratory cannot do that on its own. It needs to be the full network together. If we talk about the governance of the network, that would be the administrator of your computer. And who is the governance of the laboratory network? It is the Directorate of Laboratory at the Ministry of Health. The Directorate of Laboratory is the one giving the leadership in terms of administration, laws, and regulation. And it works hand in hand with the National Public Health Laboratory or the equivalent. And the National Public Health Laboratory is the technical arm. These are the ones that do what the MOH is telling them. So this is, of course, an ideal situation, and the context might be different from country to country. And to this boss, the governance, the captain in the ship, and the captain in second, you have then the disease programs, HIV, TB, malaria, neglected tropical diseases, the research, university, private sector, and some implementing partners that play a lot of roles. They come together with the Directorate of Laboratory and the NPHL, and they form the technical working group, and they discuss the matters of laboratory services together. So that ideally would be the situation to administer your national laboratory network. Now, what are the guiding principles of the network? When we say we want to improve the network, we want to develop the network, why and how and towards what kind of targets? So since 2008, there was the Maputo Declaration, which still, if you read it today, is very, very timely and up to date, actually. And it told us that we need integrated and quality laboratory services at all levels of the health system and the network. Integrated, that means that when a patient comes, it can receive all the tests and services that it needs through one network. And we will see later how several options can be available to achieve that. There is a universal health coverage. That means access to health services for all, without causing financial hardship to the patients or the community. There is international health regulation, which means that collectively countries have to coordinate their prevention, detection, and response to disease threat. And there is the Freetown Declaration, where ASLM played a really an important role after the Ebola epidemic, where we repeated and we reminded that clinical and surveillance functions have to be conducted through a single integrated national network. And there are other guiding principles, but I couldn't list all of them here. So you see that with all those terms of reference, the laboratory mapping data can provide the evidence to shape the network according to all these guiding principles. And that we will talk about today. So when we collect laboratory data at ASLM, we have a system that is based on the tool that is called ONA. And I show you here a picture when it was the first year we were trying this out in Ethiopia. And you see Dr. Aitenu from ASLM and Africa CDC was working hand in hand with a PHI. And we used a pre-configured, customizable and reusable digital forms to collect the data offline. And we collect the GPS coordinates and service data via an on-site assessment. And we integrate to a registry where we collect all the data. And the data collection tools covers as many tests as possible and as much information as we can. And this is how it looks. So this tool is available from our website. And it has several components, and we start with, identifying the lab, at what level is it, what's the date of the assessment, and then we include the GPS coordinate with the name of the laboratory manager, etc. And then we start collecting data on the laboratory. And here you have a screen that shows that we collect data, for example, on the staff. But most of the data that we collect is actually on the diagnostic capacity, the equipment, and the level of quality management system implementation. So what is the flow of data? And here I show you an example. So I say Burkina Faso, but that's the general flow of data that we use. So once we upload the data on tablets, there is a process where when everything is completed, there is a cleaning that is done by the ASLM IT unit. And then the data can be visualized through the web. And the data can also be analyzed. And an ASLM analyst, and it has been done so far by Mr. Michael Maina at ASLM, is analyzing the data in a preliminary phase. And of course, the goal after that is to train the country team so that they can do that independently. And what happens in this analysis is we have to triangulate different layers of information through a software that's called PlanWise. And we are going to overlay the GIS data, that is the location of the capacity, the population information, so that we can make some conclusion on coverage and demand, and the road network, which is very important to calculate access of the services by the population. And this system was done in collaboration with INSTED, who has been our technical partner from the beginning. So we are very grateful that the Ministry of Health from Burkina Faso and the Directorate of Lab, Dr. Charles Sawadogo, allowed us to use the data of Burkina Faso to showcase what we can do with the mapping in Burkina. So this is a figure showing you the distribution of the 235 laboratories in Burkina from level 1 at community level to level 4, which is at reference level. This is how they look. So you see the map of Burkina, and you see in the background the road network in pale blue, and you see all the points and the dots are the facilities that have been mapped. And they are color coded. So the black one are the level 1 at community level, the red are the intermediate level, and the green are the level 3 and 4 at reference level. You can see on the right how they are distributed. And at level 3, there are 9 laboratories. Most of them, all of them are public. And then when you go down to the pyramid, you can see that there are more and more involvement of the private sector and the private not-for-profit, so the missionary facilities. So that's already a nice way to visualize. And you can see that the network covers most of the country, which is really nice. Now, what is important is to start then analyzing. Visualizing is good, analyzing is better. And the first case study that ASLM wanted to use and we were interested in was to assess the implementation of the tier-specific minimum testing package in Burkina Faso. So here are a few definitions. So the first is that the national norms for medical laboratory testing in Burkina Faso, that's that yellow-green document that you see on the right, which dates from 2009. And that's what the Ministry of Health used to guide what kind of testing should be done at each tier of the network. Then we have used data on the population in Burkina Faso, and we took the database from the WHO, but Michael can confirm that afterwards. And the population is around 20 million. That's the most recent estimate. And then we use a definition for coverage of services, and we define it as access to care within a radius of maximum 2-hour drive, either by car, by a motorbike, or by foot. So then how do we do that? So we have used the LabMap data to compare the norms from Burkina Faso to the practice on the ground. And here you see on the left a kind of representation of all the lists of diagnostic that we have in the ONA tool. So I summarize them into 10 points. But actually, we really covered more than 120 diagnostics from different diseases that are all in the questionnaire of the ONA tool. And it covers HIV, hepatitis, Ebola, bacteriology, blood banking, etc. All of this is in our data collection tool. Now, what we've tried to do is, of all these tests, what is filtered and what ends up into the priority of Burkina Faso Ministry of Health. So out of this 120-ish diagnostic, how many of them end up being in the norm? So that's the first thing that we had to compare. And then finally, when we look at what is on the ground based on the data we collect, we have the actual availability of tests at each tier of the network, and then we represent them as a percentage towards the full implementation. So let's look at the case of HIV and tuberculosis diagnostics. What happens with those tests? So here I show you what the national norms recommend in terms of HIV and tuberculosis and what is actually in the norms from Burkina Faso. So you see in the case of HIV, all the tests that are captured by the ONA tool. So we capture HIV drug resistance test, the viral load, the early infant diagnostic, and the preparation of the DBS, etc., all the way to rapid diagnostic tests. So here, is it in the norm? When you see that the box is checked, it means that Burkina Faso consider that in the norm. So they consider viral load, they consider ELISA test, and they consider rapid diagnostic test in their norms from 2009. When you look at tuberculosis, then we have all these tests here that are captured in the ONA tool. So the drug susceptibility testing, first, second line, the gene expert, the LAMP, the LAM, etc., all of these tests. What is in the norm of Burkina Faso? We see that at that time, only the acid-fast bacilli and the microscopy was in the norm of Burkina Faso. So that's what we are going to study. Now, when we look at the analysis, how does that translate? How is it implemented? And we see on the right what are the tests for HIV that are recommended at each tier. And we see that tier 1 at community level, only rapid diagnostic tests, antibody tests for HIV are supposed to be there. At tier 2 intermediate, there should be rapid tests, the ELISA and the viral load. And at the reference level, there should be the viral load, the serology. So tier 2, 3, and 4 actually have the same recommendation. So when we look on the right and we see how much those tests are implemented, we see that at reference level here, level 3 and 4, the viral load is there in 78% of the lab. Remember that we have 9 reference laboratories. Rapid antibody tests are available everywhere, at reference, intermediate, and also community level. But when we look at viral load, it is surprising that no laboratory at level 2 has the viral load, and only less than 50% of the laboratories at reference level actually have the viral load. So that is the gap currently between the norms of Burkina Faso and the practice. Now, when we look at the microscopy, which is the norm for tuberculosis based on Burkina Faso decision, and it should be available at the 3 level, we see that it's available in 78% of the reference lab, in a little bit more than half of the intermediate level, and a third of the level 1, whereas microscopy could easily be implemented at community level. So let's have a look at also something that was interesting. We realized that actually on the ground, the practice was sometimes ahead of the norms, and especially within the tuberculosis program, which is probably illustrating how dynamic that program can be. And you can see here on the right, all the tests that we found that were in place in the country, the fluorescence microscopy, the TB lump, the culture, the gene expert. You see how many laboratories here at level 3, level 2, and level 1 implement technology that is not in the norm. They are ahead of the norm. And I highlighted the gene expert in green, and just to show that at reference level, there was no gene expert, but you have them at intermediate and community, which means that really it's about bringing the gene expert to the community. And we saw that the culture on liquid media is more at intermediate level than at reference level. So there can be several explanations, but that was an interesting finding. So really the conclusion, and we discussed that with the Directorate of Laboratory, the norms of Burkina Faso really need an update to be up to the technology of 2021 and really to address the testing need of the population. So now let's go back to that figure where we look at the list of the data collection and what is available at each tier. There can be another layer of analysis, because what we see here, when the test is available, that has implication in terms of population covered, theoretically, in the catchment area of those laboratories that are capable of providing the service. And then when a lab doesn't provide the service, this also has implication because some population will not be covered. And that means that there are indeed implications for universal health coverage targets. And then the question of prioritizing the improvement for Burkina Faso will then be posed. So this is when we do this analysis, this is what Michael, this is the kind of screen he has. He has the points that represent the facility, he has the road network, and then he has these different shades of colors that represent the density of the population that is going to be covered at 2-hour drive. This is the kind of images that he sees. Now, when we look more in detail and we really just focus on some services, this is the distribution and the population coverage for HIV viral loads. We say that there are 9 laboratories at reference level. 7 of them provide HIV viral load level. And you see them as green dots with a red cross. These are the ones with the HIV viral load. And then when we correlate that with the coverage of the population within the 2 hours travel, then 59% of the population is in theory covered by HIV viral load diagnostic services. Now, when we look at the microscopy for tuberculosis, 100 laboratories across the different levels conduct microscopy, and you see them as well with a plus sign. And you see that they are really spread across the country. So there's a good population coverage. However, we know that microscopy is not the most reliable and easy technique to diagnose tuberculosis. So that also has some implication in terms of having clinical and public health outcomes. Now comes the what if scenarios. What if the Directorate of Laboratories and the Technical Working Group could change some things and improve the laboratory network, or optimize the laboratory network, since this is a word that is now used very often. So we chose a case study and we asked ourselves, how can we increase the population coverage of HIV viral load? And we choose different, a stepwise approach just to give the possibilities. And we started by bringing the non-conform laboratories to the norm. So the one that should be doing viral load and that are not doing it, what if we bring them to the norm? The second option is to integrate viral load testing to existing gene expert sites that are actually working in the TB program. And the third one would be to place new viral load capacity in case there is still an unsatisfied demand. So how does it look like? If we want to improve the population coverage by increasing compliance to the norm, we would bring all the tier 3 and 4 laboratories to the norm. Here they are, that's the same picture. And we see that if we take this laboratory here, the Centre de Recherche en Santé in Nona, and we activate it for viral load as it should, then we would have a population coverage that would go to 61%. And then if we activate that one here, actually it's in a region that is overcrowded with HIV viral load services, then the population coverage would theoretically increase from the 59 we had at the beginning to 61.32. So it's okay, but it's not that much. So we need another solution. And then the Directorate of Lab and the Technical Working Group can say, well, why don't we decentralize viral load testing toward the gene expert sites? And here you would see the gene expert sites are the one with that cross, the diagonal cross in the country. And what would happen is that you see, I highlighted with a red arrow, the one that are in an area that is not covered by another viral load laboratories. And if we activate those 4 gene expert sites, there are 8 in the country, we decentralize the viral load there, then the coverage increases from 62 to almost 68%. So then we get a few additional points. But then if we would like to have a coverage of 80%, and I think that's one of the targets of universal health coverage, where do we place new capacity? If we bring the laboratories to the norm, we use the existing capacity, and we still have a gap. What Michael has done with the analysis is he plots all the different facilities that you see here on the x-axis. And he looks at what is the unmet demand, what is the population, the level of population that is not covered within this 2-hour drive. And he can see that 700,000, that's the maximum. You have a few sites where 700,000 populations are not covered. And then he identifies 18 critical sites, really where 400 to 700,000 people cannot access viral loads. And then those sites, you can see them here, they are in red. And you can see that this region, the Centre Nord, the Est, and the Sahel, are the one where most of the unsatisfied demand are. And then we can choose the two here that I highlighted with an arrow. And if you choose these 2 and you place new capacity in level 1, you can see that the population coverage is going to go up to 72%. So still you're not at 80. So what do? You can repeat the analysis. You remove the sites that you activated, and then you continue, and you see that when you do the analysis, then the level of unsatisfied demand goes down, and you repeat the operation with the next, sites. you continue the simulation until you feel that you have reached your goal. So there are key considerations in doing this analysis and some limitations that I would like to share with you. So first of all, one key consideration is that the choice of bringing laboratories to the norm, to place new capacity, or to integrate viral load testing on gene experts available within the TB program, that depends on the priority of the government of Burkina Faso for that example, but all governments. So they have to decide what fits their needs. Secondly, we have used population density for those calculations. It is not necessarily, the demand in viral loads is not necessarily correlated with the population density. It's possible that a single laboratory in an urban area covers most of the needs for the people living with HIV. It is also possible that HIV positive people in rural area, they ignore their status because no site is capable of offering testing. So it's not always easy to actually realize where are the patients, or whether the patients are being missed by the system. And then we know that the outcome of this analysis might be different if we had used the HIV prevalence instead of the population density as a proxy, but that is still something that is possible to do in another layer of analysis. Finally, if the government chooses to implement new viral load capacity at community level, and that means at tier 1, and currently that's not the norm, then supporting system has to be factored in. So we need to really have consideration to assign new staff, train staff at a level where the recommendation is not there. We have to make sure that there will be equipment maintenance, there will be external quality assessment, supply chain. We have to make sure that the result will be reported, otherwise there's no point placing new capacity. And then the availability of ARVs, etc. All of this needs to be carefully considered before placing the new capacity so that you don't make your system actually you don't make it more difficult for your system. Then now, what are the perspectives for Burkina Faso? So ASLM and Africa CDC and partners will consolidate the portal of data of Burkina Faso that will be fully available at the Ministry of Health. It already is, but we'll consolidate that. We'll train the Burkina Faso data team to use the data and run their own scenarios and simulation. And what will they do that for? To develop, adjust, and optimize the performance and capacity of their network. They can also quickly identify the sites that can be activated during an outbreak response. For example, the gene expert site, can they do COVID-19 testing quickly for PCR and for a maximum population coverage? They can monitor the implementation on the recommended minimum testing package or essential diagnostic list. And they can guide the mutualizing of resources in general. For example, if I have only one medical microbiologist in this region, can he or she cover this kind of population? And that's important because this data can be used, those scenarios can inform national plans or funding requests, and that's what the LabCoP is actually all about. Get the evidence, package that into a funding request, and send to the PEPFAR or to the Global Fund. So the system can also improve existing sample transport system. Burkina Faso has a fully integrated system, so they didn't need that. And of course, we will work with Burkina to establish a system to continuously update the database. That was the perspective of the program itself. So here I show you all the different countries that are on their way or have finalized their data collection. Niger was the first one. They integrated their data with DHIS2. So we have Cameroon, Guinea, and Mali that are finished, and they still need an extra push really to exploit their data. And you see this list of countries here: Gabon, Chad, Congo, Sao Tome. We have started the training and the collection of data at reference level with the help of Africa CDC. And we have collected data in many countries with different contributions from partners and funders that I would like to acknowledge here. IDDS, GHSA, the Fondation Mérieux in Niger, GHSS in DRC, IRSF in Burkina Faso. So to continue on those perspectives, ASLM, we want to ensure that all countries that completed the collection are trained and fully independent. So the next on the list are Guinea, Mali, and Burkina Faso. We want to finalize the data collection in countries that started, and we hope that we can continue doing that in collaboration with Africa CDC. We would like to link the data update to national system for laboratory registration and licensing. And hopefully, we would like to continue collaboration with partners, also working on GIS-based laboratory improvement to share the data. And I'm especially thinking of FIND and their OptiDX. They also have a nice system. This is a picture of the trading in Cameroon. And I would like to end here and really acknowledge the founder, the Resolve to Save Life, the African CDC. Really a warm thank you to Dr. Charles Sawadogo in Burkina Faso to allow us to present the data, ERSF, the team at ASLM that does the data analysis instead, and the Bill and Melinda Gates Foundation who provided the initial funding for this study. So don't forget the ASLM 2021. Please send your abstract, and registration opened yesterday. Thank you very much.
Thank you very much, Dr. Pascal, for the wonderful presentation and interesting analysis coming through. We have lots and lots of questions in the chat box. So I'm going to be checking them. Hopefully we have enough time to address all of them. So maybe just quickly to just address this one where you mentioned the website and say then there's Basundara who's asking, nice to know this is available. Where is it found in the website? So my colleague Margarita had already inserted the website into the chat. So I've just also added it for those that are coming through. And then Limbikani from Malawi. Thank you, Limbikani, for joining. Says, integration of laboratory services has proved to be difficult because donors are interested in a specific department of their interest. And he put the note in capitals, not all the laboratory departments. This has to be rectified. I guess this is a comment. You want to respond to that, Pascal? Okay,
so when not all the department, you mean that HIV and TB are concerned about
and sort of neglecting the rest?
Yeah, no, I think it's a very interesting comment, and I was reflecting, with my team when I was preparing this presentation. I think that integration comes, was specifically mentioned in the Maputo Declaration, and at that time, when we talk about integration, we immediately think about technology that is really very useful, like the GeneXpert. At that time, the GeneXpert was not even really that popular. And I think that what was meant is exactly what you are saying. It means that the silo of HIV, the silo of tuberculosis, and maybe to a lesser extent malaria, needs to now move towards integration of the services within the general network. And now it is being interpreted as, yes, we have to integrate on a single platform, but not necessarily. It's for the patient coming and seek for laboratory testing, it has to be like a one-stop shop for him, whether it's on the same platform or not, or from different instruments is irrelevant. I mean, integrating on the same instrument can be part of the solution, but I do not think that that's what the Maputo Declaration was all about. So I agree with you, and we need really to bring all the departments together and see what does that mean for the different programs and for the patient-centered services. What does integration mean?
Thank you, Pascal, for the response. And moving on from, I think, that comment as well, I want to move on to Heidi, because I think it touches what you have just also touched. Do the norms call for on-site testing at all the sites, or could also include access to specimen collection and referral for testing?
So if you are talking about the norms, so every country is has the authority to develop their norms. So the norms that we saw in Burkina Faso are norms that are recommending different tests at different levels, and they are also recommending the type of instruments, the number, and the specialization of the staff at each level. So it's really embedding the test into what kind of resources Burkina Faso is now wanting to put on the ground in order to deliver the services. Now, in the next iteration of the norms, I think that Burkina Faso might now want to define what kind of tests can be referred to a higher level if this services is not supposed to be done at this particular facility.
Thank you once again. I'm going to combine these two questions where I think it's Limbikana again who's asking, is there any reason why they don't use GeneXpert at level 3 and 4? And there is also another comment, I can't tell exactly who it is, who says, interesting analysis, but good to learn that level 1 labs have GeneXpert, even though the norms haven't prioritized it for level 1.
Yeah, that's an interesting remark, and I think that in a country, it probably illustrates the fact that the TB program is very dynamic. But I mean, I cannot preempt and talk on behalf of Burkina, and I think we might have Burkinabe colleagues on the call that maybe can explain, you know, why the GeneXperts were available in lower level. I think. In practice, there are many considerations. You know, the program may have other agreements and may have other strategic objectives than the Directorate of Lab, and really takes the opportunity. So altogether, I think it's very positive.
Thank you. Thanks again. There's also a comment which is talking about, I think it's talking about the 7 districts, where he says the best way to increase viral load testing is to establish viral load testing sites in the remaining districts. Why does the MOH not consider doing that? Is it due to lack of funding?
That could be. So at least I don't want to talk on behalf of Burkina. I think it's very courageous to, you know, to share the data so that we can all learn about the challenges. It might be lack of funding, it might be other priorities, it might be the lack of evidence. And this is why the LabMap is so powerful, that, you know, we bring the visualization and we actually bring the data just to point out to the Ministry of Health and to help them making the decision. I think this is the point of this collaboration.
Thank you, Pascal. There's so many questions, so I'm tempted to connect one or two. But as I'm just checking the chat here, there's one that sort of, let me delve a bit and concentrate on the tool itself. And Godfrey says, does the tool capture other variables or indicators like equipment, which is critical for making decisions on resource allocation, as well as leveraging on lab testing profile and capacity?
So yes, so the tool captures the large equipments, instruments, large equipments, the profile of the staff working. So for example, we capture the number of pathologists, medical microbiologists, nurses, etc. We also capture the implementation of quality management system, whether a laboratory is accredited or is engaged in SLIPTA, is certified, etc. So this is captured, but of course there is a limit to the information that we can capture. It needs to be updated, and we also try to keep up with the technology. And really, this year we added the COVID-19 in the list of the diagnostic that we had, and we really need to keep up with what is going on. The field is moving very fast.
Thank you. Picking from your last term, the field is moving very fast. Francis here says, it looks like, given the Burkina experience, looks like practices are ahead of the national norms. Are they generally funded well by donors?
So in practice, we know that when an area of diagnostics is funded by donor, it goes faster, right? So I think that one of the opportunity for Burkina and for many of the countries on the continent is to take the opportunity of developing the national essential diagnostic list. I think that now that there's the new initiative, you know, making sure that the list of diagnostic that are going to be chosen to develop the network are really in line with the disease burden, in line with the technology, and can move on. But it's true, you know, HIV, TB in general, and now the COVID-19 are well funded. And it means that these diagnostic will be ahead of the rest. You know, I mean, if we would look at the diagnostic instruments and technology for antimicrobial resistance, for example, or, you know, those areas that have been neglected for a long time, although there's a lot of interest for AMR, we would see probably a worrisome pictures as opposed to maybe tuberculosis and HIV.
Thank you again, Pascal. Very powerful analysis of data. Says, I think this is Job, which shows, you know, how coverage has been achieved and things like that. And then there are also quite a number of questions, and I'll just pick one of these from trying to find the name, who was asking, what about the private sector in terms of integrating them? I think my question just disappeared here. In terms of how important to include them.
Thank you. I think it's a recurrent question, how to include the private sector. I mean, in reality, the private sector shouldn't be excluded because they are operating under a legal and policy framework that is defined by the government. Now, how this is enforced, you know, and how much resources government can devote to include the private sector is probably now the question. So I think that when a policy or a recommendation is released, there should be some consideration for whether or not the private sector should follow them, to what extent. I think that the private sector is registered and licensed, and those requirements should be looked at, you know, when licensing the private sector, making sure that at least they would have a level that maybe it is not the same tier level as in the public, but they have to be fully integrated into that collective effort of the network. So when I speak about the tiered network, I absolutely include the private sector, and I think it would be wrong to have a totally parallel system.
Thank you, Pascal. Coming back to the two again, Daniel Kimani. Thanks, Daniel. He says, did the two collect information on platform utilization versus capacity? Sometimes you have some equipment underutilized in some regions, while others are underserved in other regions. This can help in strategic and complementary placing.
Thank you. That's an excellent question. And I think that we have a preliminary analysis and a lot of things are theoretical. You know, when we say 50% of the population is covered, provided that the instrument even have usable capacity to cover this population. So as of now, we are not collecting this kind of data, but we could think of a system to append some modules and really in real time monitor exactly the capacity that is used and unused for each instrument. That's an excellent point.
Thank you once again. There are quite a lot of questions that came through, so just maybe taking a few more. I know the time is moving. I think this comment also from Stanley Bulime says, regardless of population coverage, small marginalized populations in hard to reach areas need consideration when mapping lab equipment. And it takes me to that analysis where you're looking at distances and related issues. Can you comment on that?
Yeah, that is right, and that really comes back to how difficult is it to prioritize, you know, for the Directorate of Laboratory, because, you know, they have pressure from the program. They need to have their target, so they tend to have the intervention in those areas that have most of the patients and you know, where you can really show the quick wins. But then you have those populations that are really very remote, and this dialogue needs to happen with the technical working group and carefully consider what are the ethical issues, what are the equity issues, what are the programmatic issues. I totally agree with you, and all of these perspectives need to be debated together in this discussion to prioritize where the new capacity has to be placed. And I think that the civil society there really has a role to play.
Thank you, Pascal. Alidu Smaila says, I think it's taken from the list of countries that you have shown that they've already sort of tried to map their capacities, over 15, I guess. What is the process of joining this? Is the tool freely available?
So the data collection tool is freely available. So that's not an issue. So it was a little bit of an opportunistic, how can I say, enrollment of countries. A couple of years ago, Africa CDC really wanted to push the initiative. I think that we considered Central Africa, where the RiselNet was starting its activity, and also the Southern Africa, and we collectively trained the countries in those regions. And then, we were opportunistic in other countries and really tried to synergize the funding with also with what the country feels is a priority. So no, the tool is open source, but there is an initial investment that has to be done in terms of collecting the data, putting the data portal in place, etc. So it is open source, but it's not. But the process is not for free. I mean, I'm not sure it makes a lot of sense, but that's the situation.
Indeed, a lot of resources and expertise going through. So hopefully, I think that also gets improved. And there is Kapur Gita, who says, is there any, I guess he wanted to say, any unified continental norms at present? It might be a good step forward so that there is some bit of standardization. What do you think?
No, I think it's an excellent point. And, I had that discussion with some colleagues that have the same concern. I think especially from colleagues from FINE, we need to agree on what a tiered network is supposed to do in the ideal situation. What is the endpoint we are looking for? And, even before we use this lab mapping, we try to integrate, we try to optimize, we try to do point of care. What exactly are we trying to achieve? So I think it's a very important point that you make, and we are working on it with the different stakeholders and experts in the field.
Indeed, a very important point, and also mentioning, I think, some of the work that is done within the IDC to try and bring this approach to be as common and not repetitive as well as possible. I also find this comment from Fred Babu very interesting, and he or she is asking, first of all, he says, very good presentation. How frequently is remapping of temporal reference networks done to achieve efficiency?
Yeah, that's a good question. I think for me, I would have a vision, which is my vision, but it would need to be implemented. I think if a system is in place, all laboratories operating under the network, ideally they license or they relicense every year or every 2 years. At the moment when they are relicensed, collecting this data, and then when the system is in place, the lab manager could really take his tablet or his smartphone, enter the data, what changed, what didn't change, what is in place, and make sure that regularly this data is updated. It would be a nice way to start. And it would be a very powerful tool to understand, okay, what are the labs that are in conformity or the labs that are in non-conformity? Let me register them. And of course, there can be also a continuous update when, for example, there is an event like the COVID-19, and really we have to upgrade our diagnostic very quickly. It's not difficult. When the system is in place, honestly, it's really about entering the data in the platform, it can stay open, and the directorate of lab can have real-time data and an overview of what is going on the ground.
Yeah, thank you very much. And there's someone who's saying, can we use any other open source packages? You mentioned EpiInfo, that may be feasible. I know in your presentation you mentioned other tools like OptiDX. Maybe you want to comment on that.
Yeah, I think that we are still into construction. So Michael is the one that is doing the analysis. So he uses PlanWise, and I think he's creative enough to look for other statistic package. I know that for the sample referral and the distance, you know, how lower level have to refer to higher level, I think he uses another statistical package, so that's possible. And I really hope that the database, you know, the extraction is in like a CVS Excel format. So there is nothing that stops the country to say, okay, this is the database, and says, okay, we give it so that OptiDX can make the analysis. All of that is possible.
Thank you very much. Maybe I'll take this last comment from Heidi, who says, we should always think about integrated sample referral always, even if integrated testing is not appropriate for all settings. I think an important point indeed. All right, I think we have tried to take as many questions as possible. I just want to give a few last minutes to Pascal to try and sort of summarize this and give a bit of remarks and what is the way forward.
Thank you, Anafi. So that was a pleasure and an honor to present this, because we started this, you know, in 2017, and that's been really hard work. And now seeing everything coming together is really nice. So I can see still questions coming in the chat. What is the difference between this and diagnostic network optimization? This is it. This is, you know, you can optimize your network using this data, but in addition to optimize the network, you can manage your network from an administrative point of view, even with that. So these are principles that overlap, but that are not completely the same. So just to conclude, I think that it's a powerful tool, the ASLM tool. It's not the best. There are other tools, and what I would wish for the networks on the continent is really take advantage of this kind of data, of the GIS data, and really bring the network into the 21st century, really manage the network. Things can go faster, they can go better in a more cost-effective way if we use this sort of evidence to do analysis and conceive, you know, the network, make sure that we deliver the services in the best way.
Thank you, Pascal. It's been a wonderful session. Lots and lots of questions that are coming through. As usual, we'll try to look into the chat and try and respond to those questions that have not been addressed today. We touched on a lot of important issues of coverage, issues of equipment, issues of utilization, diagnostic integration that came through, route optimization, you know, lots and lots of questions that came through, and also comments. It has been a wonderful session indeed, and we pledge to continue to bring this to you as usual. So look forward to the next announcements that we should be sending in a week or two. Till we meet again, and have a good day, good evening, good afternoon, or good morning, depending on wherever you are. Thank you.